let's go through this question now. We've got a 80-year-old man with a previous history of psoriasis. He's got a 6-week history of pain and stiffness of the left knee and a swollen right index finger. And the pain is worse in the morning and is associated with the early morning stiffness lasting more than 30 minutes, which is improved with use. So when you examine the patient, the synovitis of the left knee is confirmed. Where do you go next? Okay, what do you do next? So this is a 30-year-old man with a previous history of psoriasis that's got a 6-week history of pain and stiffness of the left knee and also the swollen index finger. Pain is worse in the morning. It's got early morning stiffness and gets better with time. So where do you do next in terms of investigation? You go A, ultrasound, B, CCP and rheumatoid factor, C, FBC, a full set of blood tests, D, chest x-ray, or E, specific x-ray of the hands and feet. Have a think. I'll give you 4-5 seconds. Well, let's think in terms of the diagnosis first, guys, right? So this patient's got psoriasis. He's got asymmetrical oligoarthritis. So that means he's got asymmetrical left and right side. And he's also got the left knee and the right index finger. So this is asymmetrical completely. And he's got morning stiffness. So this suggests to me that he's probably got psoriatic arthritis, which is a chronic inflammatory joint disease, which is associated with arthritis, okay? And that's often got some of the following features that's important. It's got asymmetry joints, so DIP, spine, sacroiliac, knees, etc. It's got dactylitis, so sausage-like fingers due to inflammation of the entire digit. And also they sometimes have enthesitis, which is the inflammation of the insertion point of the tendons and ligaments. They may also have some nail pitting changes, pitting, onycholitis, hyperkeratosis, etc. And also the fact that the vast majority will have negative rheumatoid factor, negative anti-CCP. So, a couple of things. One, you could do ultrasound. That's useful to detecting things like synovitis, enthesitis, dactylitis in psoriatic arthritis, especially when the clinical examination is rather equivocal. However, we already know this patient has got synovitis of the left knee. We've got that on examination. And so even though the ultrasound of the feet may give us additional joints that may be involved, is not the next important investigation because the diagnosis can be made just on the clinical presentation and the history of psoriasis alone. CCP, rheumatoid factor, is not correct because it's not likely to be rheumatoid arthritis given the fact that this is asymmetrical oligoarticular arthritis, whereas rheumatoid arthritis involves the small joints of the hand and is much more symmetrical, as we discussed. What about C? FBC, renal liver biochemistry. That is correct, okay? It's very essential because we're going to need to treat psoriatic arthritis. We're going to treat it aggressively with DMARDs, methotrexate, leflunomide. And so this is about long-term management of psoriatic arthritis, and that can cause bone marrow suppression, hepatotoxicity. So checking the full lot of baseline is important before we can monitor this medication. Now, sometimes people do chest x-ray before starting certain DMARDs, especially methotrexate, to rule out pre-existing lung conditions, TB, etc., or serves as a baseline if we're trying to monitor pulmonary toxicity, but certainly not needed for psoriatic arthritis. X-ray of the hands and feet, that may help us assess the extent of any joint involvement or damage, such as DIP joint erosions, anything like that. However, it's not the most important because it's not going to guide the initial management, and the initial management guidance is going to be aggressive DMARD. And to do aggressive DMARD, we need to know the baseline before we can commence it. This is just a generic photo for you guys to have a remember what psoriatic plaques look like. Look at the silver scales. Look at the pink base that's clearly delineated. This is psoriasis, okay? So you may get a picture of this. You may get a description of this rash instead of giving the actual diagnosis. These are all possibilities in the real exam.